of all, I would like to definition. What is complete anatomic repair? Anatomic repair is the repair of the torn infraspinatus and supraspinatus tendons to the footprint under appropriate tension. There are some goals to treat this massive tears that biomechanically, as we know, rotator cuff provides force couple balancing and dynamic glenohumeral stability as the humeral head depression and compression. So first we restore this, and the anatomy is quite different as we learned before. Now we know that the infraspinatus is occupying most of the tuberculum majus, as you see from posterior to the anterior, and the wide trapezoidal footprint. So advantages of the anatomic complete repair: re-establish the force couple balance and more tuberculum majus coverage. So increase function, reduce re-tear, and prevent cuff tear arthropathy. But we have some problems to make the anatomic repair. First, retraction of the rotator cuff, delamination, hypovascularization, fatty degeneration, and strain. So it's ended up the re-tear. So we need the stepwise technique to repair anatomically. Is it possible? Yes, it is possible. How? First, recognize the tear pattern. The second, identify delamination. Then release and mobilize the tendons, and margin convergence, which is very important, and tension-free repair to the bone. This stepwise mechanism gives us the opportunity to treat anatomically. So first step, recognize the tear pattern. Most of the massive rotator cuff tears not U-shaped, it's distorted L with deep split traverse glenoid. As we see here, yes, this is L-shaped tear and split go beyond. It's important. And the second, identify the delamination. It's important to and should be debrided and stirred together. Sorry. And the third, release and mobilize. The release process should posterior and posterior medial, because the massive rotator cuff tendons displaced posteriorly and anteriorly, not medially. So good release at the posterior medial and posterior cuff facilitates a tension-free repair. And mobilization should be from posterior medial to the anterolateral. We don't try to mobilize the tendon from medial to the lateral. And another release and mobilize technique is interval sliding. I don't recommend this. Why? Because it's not allow the sufficient mobilization, and another risk is devascularization of the specifically supraspinatus tendon. The margin convergence technique, which is very important to make the anatomical repair. The important point of the massive tear, it's L shape, and the pivot point, which is most medial part, the top of the L. So we have to make stitches from posterior to the anterior direction. As the posterior margin converges to the anterior, then the strain on the lateral edges, which is treated to the bone, the stitches to the bone, will decrease. Is my patient is 58 years old lady. First, we describe the tear pattern. As we see, the deep split go beyond the glenoid, and it's L shape. Then we pass the sutures from anterior and posterior and get together these margins. Then we make it 3 stitches. 2 or 3 stitches is enough from posterior to the anterior. Then the lateral edge, I use the lateral side of the tuberculum majus, the single row fixation to the bone. and it's ended well coverage of the massive tear. It's anatomical coverage. We know that the lateral side tension is important and retracted tendon is shortened. So, and the anatomic repair increase the tension. So if we make the complete release and repair posterior to the anterior, can decrease this tension. And another important point is, if we use to repair to the bone double row, it's commonly type 2 re-rupture can occur. So to avoid this problem, I always use the single row to the lateral side. What is going on in the literature? This is 2020 and 2019 studies, 34 complete, 30 partial repair, mean follow-up 32 months. The all clinical tests is, there's no significant difference between this test, and both treatments were found to be successful. Muscle strength significantly inferior to partial repair group. Another good paper, systematic review, 233 patient complete repair and 208 partial repair with a 24 to 45 months follow-up. Both treatments were found to be successful clinically. Partial repair group has more reoperation, but radiologic integrity, MRI arthrography in complete repair is 62%. So complete repair is the first line of treatment. Another systematic review, 26 studies, 1,405 patients, mean follow-up time 39 months. Both treatments resulted significant improvements in pain, range of motion, and functional scores. And repair failures, 35% in complete, 40% partial group. Another good long-term study, 64 shoulders, 44 complete, 20 partial repair. Mean follow-up time is 8 years. Both repairs grant satisfactory clinical outcomes in long term. And partial repair shoulders had lower muscle strength. This is my last literature. Another good paper, 58 patient, minimum 5 years follow-up time, 25 complete, 33 partial repair, no significant differences in clinical outcomes. Our return rate is quite same. So the conclusion is the arthroscopic repair is viable option for the massive rotator cuff tears, and complete repair should be attempted whenever possible. But it may be preferable to perform partial repair rather than aggressive tension in massive rotator cuff tears to achieve complete repair. Thank you very much.